There's a lot of talk of primary care physicians leaving their specialties after COVID. What are the ways that you stay just to maintain your well-being and your enthusiasm for your work?
I don't really understand how primary care gets burned out. I mean, honestly, every room is a crapshoot. I mean, I go from room to room and it is different all the time. I could do a follow-up for diabetes in one room, marriage counseling in the next room, diagnose a cancer in the next room. It is initiating insulin. Everything is different. So I find it very entertaining. I mean, I find it very stimulating. It's all so different.
You are listening to the Pinnacle Podcast, where we empower women in medicine through education, community, and actionable strategies for both the practice and the business of medicine.
Medicine is a lifelong career, and continuing education is crucial for professional development. Pinnacle is the first and only multi-specialty organization dedicated to addressing the challenges that all women in healthcare face.
Welcome to Pinnacle, the elite professional community providing education for women in medicine. At Pinnacle, we challenge you to pave your own path by helping you develop the skills needed to not only stay in medicine, but to excel. Hello, everyone. I am very excited to be here today. We are talking with Dr. Karen Grant, and this is the Pinnacle Prescription Podcast. I am one of your hosts, Dr. Rupa Wong, and Dr. Grant is a family practice physician, but she also has a very unusual extra board certification that we're going to talk about a little bit later. And we're going to unpack everything today about what it means to be a primary care physician in this day and age, how you can manage the high number of patients while not burning out, and also maybe balancing motherhood if that's right for you. So Karen, thank you so much for being here today.
Thanks for having me.
All right, let's just dive in because I think this is going to speak to a lot of physicians in general, but really specifically primary care physicians who have an extra set of challenges and hurdles and obstacles that you guys face that sometimes us surgical subspecialty folks do not. So first, just tell everyone a little bit about the kind of medicine you practice and where.
I am in Fort Worth, Texas. I have been practicing since about 1998. I did my residency at UT Southwestern, and then I did my family practice at Baylor in Dallas. And I have been in private practice in the same practice since then, since I took, I think, a week off and started on July 7th. So it's been wonderful. I do primary care. Don't really see a lot of children, so I see from 12 years on up because mostly the adolescents. I didn't want to have to do with the vaccines and all of that. It's just too much to keep up with in terms of storing it, basically. Oh. So I see 12 years on up all the way through hospice. So I'm a hospice director as well. So I get to keep all of my patients all the way through. So I've managed now to build up 4-generation families, which I love. And then I also do aviation medicine.
That is so neat. I didn't even realize you did that. So share with us what that means and what that entails.
So an aviation medical examiner is an employee, or it's arranged by the FAA. So I'm not an employee of the FAA, but I work with the FAA as an AME. Basically, every pilot and air traffic controller that works or flies has to have a medical license. So your third-class pilots have to have a medical license that's done every 3 years. Those are the little guys that fly around on the weekend in their Cessnas. A lot of doctors do that, I know. And then there's second-class pilots like commercial pilots, UPS flights, FedEx, DHL, and even some of the medical pilots, the helicopter pilots and medical planes. Those are second-class pilots. They need to be seen every year. And first-class pilots are the United, Delta, American, all of the airline pilots. They need a first class every 6 months. Air traffic controllers get a pre-employment physical, and then every year thereafter. So sometimes we'll do pre-employment fairs where I'll just see 100 pre-employments in 2 weeks. It's an all-cash business. Air traffic controllers pay us. We are paid through the FAA, and then the pilots pay us for the first, second, and third class. So it's just a cash pay addition to my private practice.
That's so interesting. I had no idea that even existed. I think I just assumed everyone just went with their
Went and
insurance.
flown. Yeah, well, it's
Yes.
important, and it's changed a lot since I've been doing it now. I've been a senior AME, which means that I can do first class pilots for 26 years, and you have to have a 98% correct rate as a junior AME before you can do first class pilots.
Being a senior. That's amazing. And that's a
So
great
we do a lot.
supplement for your
It is. There's
practice.
a little bit of upkeep. Every 3 years, I have to go and do a CME course to keep it all fresh. But it's fairly redundant, and it's no more difficult than any other CME, and it helps to keep my CMEs up. So it's nice.
I love it. It's so fascinating. But let's get back to just the general family practice, family medicine. What inspired you to choose that? What keeps you passionate about it despite all of the intense demands of the schedule?
Interestingly, when I got out of medical school, I was accepted and was planning on doing anesthesia.
Oh,
And then I went to John Peter Smith to do my transitional year, which, as you know, is you just do a whole bunch of different things because you have to do an internship that's separate from your anesthesia residency. So I did, general care, OB-GYN, pediatrics, ER, and I just fell in love with primary care. I think when you're in the county hospitals, it's really hard to see the joy in primary care because primary care in the county hospital, in medical school, and sometimes in residency, it's really it's the veterans that have just another disease, or you get the sickest of the sick in the county hospital and the people that haven't been taking care of themselves. And it's just so frustrating and quite frankly, kind of depressing. But when I got into the private family practice residency that Peter Smith is here in Fort Worth, it was a lot better. These were people that were taking care of themselves, and they actually listened to you, and they had a little bit more socioeconomic IQ to be able to care for themselves. So it was a lot less frustrating, a lot less depressing, and I just loved it. So I kept on doing that.
so that shift, that's a big difference. That's a big change.
It was a
from
big
anesthesia.
difference. And then, no offense to the surgeons, I also realized I was not the kind of person to, I guess,
Just
a lot of
say it. It's
anesthesia.
fine.
A lot of anesthesia is sort of waiting around and doing the surgical things, and I'm not the most patient of people. So I decided I needed to be a little bit more in charge of me, and that helped my decision a lot too.
I love that. I remember getting this great advice in medical school where someone said you should like the most mundane aspect of whatever you're choosing. For us, it's doing glasses prescriptions. For you, it might just be, there's anesthesia. It would have been something different.
It's the high blood pressure follow-up, the diabetes follow-up, the checking of the INR every month. And it's that mundane stuff where I really feel like I can get in there and make a difference. I can take somebody that's got virtually no future. I mean, we all know diabetics that are out of control, that they're not going to make it to 50, but I can get in there and I can muck about and I can chew them out enough that they start to take care of themselves, and I can get them living full, happy, healthy lives. And I love that.
I love it. Okay, share with us a little bit about what your practice is like. Number of locations.
I have a very busy downtown practice in Fort Worth. So when I first started, I worked with a gentleman who'd been in practice for in excess of 30 years when I started with him. He has since passed away, but he also had a very, very large practice. So when he did pass away, I inherited a ginormous practice. I now have 3 additional partners. I have an off-site nurse practitioner that takes care of a lot of the mundane, redundant things that are required by Medicare. Important, but still redundant and mundane. But I probably see somewhere between, on an easy day, 30 patients, and then on a busy day, probably 40 patients a day. And that includes pilots, of which I see probably 3 to 5 a day.
I mean, that seems like a really high volume for primary care.
It is. I have a team of ladies that work with me. The one that's been with me the shortest is 17 years. The one that's been with me the longest is 26. They are the most efficient, and quite frankly, they're more efficient when we're busy. they keep me rolling. Over the years, we've delegated certain strengths to certain, there's one of my nurses, in addition to rooming patients, she takes care of all the home health paperwork, all the outpatient paperwork to make sure that the patient still needs outpatient, what it is they need specifically, how much longer they need. I just have to review it, sign off on it, and that's done. I've got another lady that's on the phone, and she's responsible for making sure the refills are up to date. I've got a different lady in my office that's just responsible referrals. I've got another lady, an offsite lady, that's responsible for something called med adherence. Medicare makes us now make sure that all of our patients are filling their medications with 80% compliance or more. And they base our pay scale based on that. It's one of the many metrics, and it's a triple weighted metric that we have to, that's one of the hoops we've got to jump through. And that is a tremendous amount of time.
Gosh,
investment.
I did not know that at all.
It is. And then there's another one of our parent company, and for many of the Medicare Advantage programs, they have identified patients who are what's called band 4 or 5. Those patients are a little bit more ill. They kind of pop in and out of the hospital a little bit more often. They're responsible for a lot of the main Medicare cost. Those patients, we are required now to sort of reach out and touch monthly, which is not that big a deal if you don't have a huge practice and you've got 20 or 30 of those patients. I have about 120 of those patients.
Oh my gosh.
So
that's making me overwhelmed.
It's very daunting. So reaching out, either those patients have to be seen every month or they have to be on the phone every month with a virtual visit. So it adds up quickly to getting very clustered and cluttered if you don't delegate very well.
Well, that was what I was going to ask you next, is how you can manage that volume of patients, but I can tell it's delegating efficiently and not micromanaging. Is there anything else that you do that just helps you ensure that you're delivering that quality care?
Absolutely. First and foremost is you keep your nurses happy. I try to be as good to my nurses as I possibly can. If they want extra education, I will pay for that. I buy lunch for my office through me, not through the company, every Friday. We have T-shirts that we wear for different things, Cinco de Mayo, or we have the Boo Boo Crew for Halloween. And so keep the ladies and gentlemen happy, because they are your lifeline. They can sink or swim you. They are they're your first line of defense against malpractice, because they're the face and the voice that most of your patients are hearing, except for that 15 minutes when you're in the room. So keeping them happy is crucial. Yes. One of the things I learned from my original partner, Bob, was you've got to spend money to make money. Mm-hmm. I have 26 employees for the 4 of us that are there. I keep a clerical staff sort of up on the mezzanine, and then the clinical staff is downstairs. So there's people on the phones, making appointments, doing referrals, doing the refills in a different part of the building. And then my clinical staff is downstairs with me, and I've got 3 different managers: an office manager, a clinical manager, and a clerical manager. And I also have lab on site, which I think is crucial for primary care. Trying to get patients to leave your office and then go somewhere else to a different lab to get them that's about 50%. You're going to get about 50 to 60% of those patients actually go in and getting their blood done. And those things really seem to have made a huge difference.
Okay. So everything you've described sounds amazing. The workflows, the protocols, I mean, just the way you treat your staff so that you have people with you for decades so they know exactly what they're doing. But how can you, I hate to say it, but let's just talk about how can you afford all of these different managers and different nurses and the way that you've set it up with falling reimbursements? Like, how do you, that's what I feel like someone else listening is like, oh, that's just not possible. But clearly it is.
With the falling reimbursements has been interesting. Because I'm a downtown practice, I do have a very large Medicare and Medicare Advantage program practice. but I also have these other things. So I teach the Southwestern medical students, which I found after I started is a paid position. I do the pilots, which is a cash part of my, at 5 of 40, 1/8 of my practice is cash only.
Okay.
I'm the hospice director, so that's a little bit here and there of extra remuneration. But the way we are paid through the insurance companies, especially the Medicare and Medicare Advantage program, is through a series of quality metrics. The quality metrics that we're graded on, especially as primary care, has been hugely daunting. The primary care doctors are responsible for the depression screening, the fall screening, dementia screening, blood pressure control, whether or not they've had an A1C, regardless of whether they're diabetic, then whether or not that A1C is well controlled, whether they're compliant with their medication, whether people have had a heart attack or on a beta blocker, whether or not your diabetics are on an ACE inhibitor, whether or not you've got their kidney function screening. There's just a huge list of things we have to get through.
Yes.
So at the beginning of the year, I don't have students in January, February, and March because I get a stack of paperwork with each of my patients that between me and the nurses, it takes a lot longer to get through. But if we do all those things and we jump through all of those hoops, we get graded sometimes it's a star score basis or whatever. The higher your stars, the more Medicare will pay you.
Okay.
The higher your stars as a group, the more Medicare is willing to pay you as a group. So we are a group of physicians. We're sort of loosely a group. We have a business company that does our contracting and our billing. We're all independent, but as a group, we have a little bit more clout to contract with Medicare and the Medicare Advantage programs. And that's been very beneficial. Originally, when I joined this practice, we were run by a group of specialists who owned and ran the group. And we got paid, and we got paid well. But we also found that the specialists were not doing all of that screening. We were doing all of the grunt work. And the specialists were getting, the Lamborghini payment. They were getting the lion's share of the work money. Then we switched over to more of a primary care owned and run group. And now we get to get more of that bonus, more of that reward for all of the work that we do. So it pays off. I mean, there's a balance, certainly. You have to balance the expenditure with the reward, because it's a big investment. I mean, I probably run at 65% overhead.
Yeah. Yeah. I mean, that's at least, but that at least allows you to practice the way that you want to practice. And
right. I have the room for it.
So you can pad it. And I heard you mention, I think, which is probably crucial, is the diversification, right? You don't just have the income from the one set of patients. You've got the hospice director, the aviation, the teaching over at Southwestern, and I
the
think
Medicare Advantage, the indemnity plans, the self-pay patients, and then Medicare only. A lot of doctors will no longer take Medicare only.
Yes.
I hate that. I hate that for them. I love it myself because these people need care. They need good care. So I take Medicare only. The only thing we don't do is Medicaid only. We'll take Medicaid second. But Medicaid's it's just too much paperwork for me to do as a primary insurance.
Yes.
I even like taking TRICARE. I have a hard time finding them specialists, but our vets are near and dear to me. So I really like trying to take care of them as well.
Agree. I take TRICARE. I still take Medicaid because pediatrics. So that's what we fall under. But
one of the reasons I don't see the littles.
Because we do. So I don't know much about Medicare, but I know lots about Medicaid.
I know a whole lot more about Medicare than I did 10 years ago.
Well, okay. So all of the things that you're doing, and even just looking at it with an eagle's eye view, there's a lot of burnout, right? With women in medicine, specifically even in primary care. There's a lot of talk of primary care physicians leaving their specialties after COVID. What are the ways that you stay just to maintain your well-being and your enthusiasm for your work? Because I know that everything you talk about is real. We talk about you still have this love and this passion for what you do, and you don't seem burnt out. So how do you manage that?
I don't really understand how primary care gets burned out. I mean, honestly, every room is a crapshoot. I mean, I go from room to room and it is different all the time. I could do a follow-up for diabetes in one room, marriage counseling in the next room, diagnose a cancer in the next room. It is initiating insulin. Everything is different. So I find it very entertaining. I mean, I find it very stimulating. It's all so different. There are days where I have follow-up after follow-up after follow-up after follow-up, but I have learned never to complain of that boredom, because then you do have to tell a patient you've known forever that they've got cancer. And so I don't complain about boredom in that respect. So I don't really understand burnout from primary cares with regard to that. Other than that, I really love what I do, and I really love going home. So I've always said it's a wonderful. I love getting up and going, and then I love coming home. It doesn't get any better than that.
I love that. I mean, it just gives a lot of hope, because sometimes all you see on these community threads is people trying to exit medicine, and to see someone that's been in the field for like 3 decades, right? Or almost 3 decades, and still loving every single aspect of it. Maybe not the paperwork, but
no, the paperwork's never fun.
Never fun.
But there's some things that you do. You do your lab work every day. You don't want to get behind on that. You do your signatures every day. But one of the things that I think, you're probably real familiar with, you've got kids in athletics. I've got kids in athletics.
That's what I was going to ask about next.
It's learning how to play the game. I was an athlete. It's learning how to play the game. And what a lot of PCPs do, and what a lot of doctors do, is that they learn how to play the game, and then they think they're done. And learning how to play the game changes every year. Medicare changes the game every year. It's just a new game. They change the rules. You learn the new rules. You follow through with the new rules, and it becomes fun again. That learning curve, that first couple months, it's never fun for anybody. Starting a new thing is never fun. But once you learn how to play the game, it's just another game.
But I think a lot of this also comes from the fact that you are an athlete. And I think you view each of these challenges as something to overcome, as opposed to something that's just overwhelming.
Absolutely. As a physician, as a woman in medicine, I think if I had the opportunity only to hire people that have been athletes in high school or college, I would, because there's no better way of assessing whether or not somebody is good at organizing themselves, organizing their time, striving, improving. There's so much more to everything we do that can be benefited from athletics.
I love it. It's literally the exact thing I was telling my kids yesterday. Both my kids had so practices, and I said, these are skills that you're going to develop. These hurdles, these obstacles, you develop the skills. That's going to serve you the rest of your life.
If you were perfect, you did not need to practice.
Yes, exactly. Okay, but we're kind of touching a little bit on motherhood. I know that you have 3 amazing daughters. How did you balance that? And they are rock stars. If people don't know, Karen's daughters are like true rock stars, each so individual and unique in their skill set and what they're good at. How did you balance motherhood with this really demanding schedule?
That's an interesting question. I had my first child in medical school. I do not recommend that. I had my second child in residency. I do not recommend that. And then I waited many, many more years and had another one. But the first 2, basically, it was, I have an Indian mom that was just so happy to come to my house at 5 a.m. and be there when the children woke up and get them dressed and get them fed and take them to school, and then pick them up from school, daycare. Obviously, we were daycare people. We had to start at 6 weeks because I was a medical student. Right. Pick them up from daycare, take them home, bathe them, make dinner, and leave it there for me so that when I came home, all I had to do was take care of and have fun with my children. It was a blessing every which way from Sunday. But I've got one daughter now who's a resident, and she has a child. And, we talk all the time about mommy guilt, how hard it is, but how rewarding it is for that baby to know that mommy's got a purpose other than her.
Agreed.
And that she is fulfilled, and a happy, fulfilled woman is a 100 times better mommy than any other mommy, whether that fulfillment is coming from staying at home or that fulfillment's coming from working your butt off in a hospital all day. It does not matter.
Does not matter at all. And I love that.
At all.
I mean, you were lucky to have such a great support system, but I completely agree
did.
that.
I was. But daycares are amazing now. The Montessori system, the Bright Child system. If you can afford daycare, it's definitely the way to go. And I can't imagine any of my children not having been in daycare. The socialization, the education, the potty training, the food exposure, everything is so much better with daycare. In my experience. So it was never a problem for me. And we were lucky enough to be able to afford daycare. And of course I was lucky enough to have my mother help me.
I love that. I love that. But your daughters are a true testament to you. I mean, you're close with them. And, I think that people worry, someone whose kids are still in school. I mean, your youngest one is, but we worry, this time away from them is going to impact, maybe we're not going to have as close of a relationship. And you're a testament to that's just not true.
Your kids always know, and you have to let them know they're not mind readers, and they're not as intuitive as hopefully some adults are. And you have to tell them, yes, I'm a doctor. Yes, my patients are important. Yes, my work is important, but there's nothing more important than you. And they know, all of my kids know, they can call me anytime. If I got text messages at 5 this morning from a sick kid in Florida, needing, mom, it's 6 text messages in a row. Of course, I'm going to wake up. I'm going to take that call. I'm going to help. I'm there for you. I am absolutely 100% here for you. Always. If you need me, nothing else is more important. So
agree. I love it. So, okay. Talking about family medicine, I mean, the way that you've structured your practice, your work-life balance, everything is very innovative, and you are efficient with everything that you do to just maximize your time with the patients. But looking ahead, can you think of any changes? What would you like to see that would happen in your field that could address some of the systemic issues that you face daily?
Most of the systemic issues are really just Medicare meddling in a lot of the data. I don't think that's going to change. It's a matter of, thank God for EMRs. When they first came out, 28 years ago, my partner was wise enough to be in there and saying, this is the most important thing in the future. We need to do this. So I've never had a practice without EMR.
Oh, wow. Even when you started, that's amazing.
As the year I started was the year we were piloting what original the original EMR that he was doing. So we've changed one time, I think, but I've never known a practice without electronic medical record, and I can't even imagine what that would be like. All the data and all the information, all the X-rays, all the labs that you can follow so easily. I think some of the HIPAA issues are going to become important with EMR as more and more companies are experiencing some information leakage or hacking. But I think the security is coming along pretty quickly with that. I don't know. I don't think, like I said, all of the rules that change, I think that as the game changes, we just learn the new rules and we keep on trucking. I don't really feel like there's a huge downside to what I do. I'm not sure I would change a whole lot of anything.
I love it. In a sea of negativity, you're so positive about your field, just medicine in general. And I think it's just something that people that are just starting out on their journey should really hear. All right.
I think you do. You do. Otherwise, it's not fun. It's just miserable. No, it would be miserable. You've got to be positive. You got to take the blows and change and keep going with the wins.
I love it. Okay. As we close, I wanted you to share one pinnacle pearl that you have for other women in medicine. What would you say?
Find a hobby that relaxes you and do it every single day.
What's your hobby?
I knit.
Oh, my mom used to knit and crochet, and it was total, as a psychiatrist, child and adolescent psychiatrist, just helped her de-stress.
I know a lot of male doctors and a lot of doctors that are now knitting because if you're good at it and you're doing complicated patterns, you cannot possibly think about anything else. You have to focus on exactly what you're doing or you're going to mess it all up. Months of work. So it does make you turn it off. But that can be, Lori does yoga. One of my daughters weightlifts. The other one plays volleyball. They all have something that occupies their mind for at least a little bit of the day for 100%.
I love it.
I think that's important.
It is getting into that flow state and separating from everything else that's going on around you.
Absolutely.
Well, Karen, this has been such a pleasure. I knew it would be full of a lot of wisdom for many people to learn from just your decades of experience and also just your positivity and the way you approach every obstacle that gets thrown your way. Are you where can people find you?
I am in Fort Worth, Texas. I am, my Instagram is Taking Karen Business. And I'm reachable.
I love it. Thank you so much for sharing with us today. I know there's a lot that's extremely actionable that I plan on putting into practice and just even mindset wise. So I really appreciate you taking the time.
Thanks for talking to me.
Thank you for listening to the Pinnacle Podcast, where we strive to elevate the voices of women in medicine and inspire excellence across the healthcare landscape. Until next time, keep reaching for your pinnacle.